Assalamu alaikum. Hello and a very good morning. My name is Dr. Shazia Maqsood, and today our topic of discussion is infertility. In OB/GYN, infertility is a very vast field, very vastly, progressively increasing information, knowledge coming in, helping the couples to be able to have a baby. So today we are going to talk about the basis and the basics of infertility, how to investigate an infertile couple, and how to manage an infertile couple in sort of a brief outlook. So this is my disclosure slide. I have nothing to disclose. Let's define infertility. So when a couple is not able to conceive after a year of having regular unprotected intercourse, this is called infertility, and they need to seek medical advice. If the woman's age is above 35, as we all know that in this modern age, what happens is that we are putting aside our plans to start a family later because we are busy with our careers. So if our age is above 35, infertility would mean not getting pregnant after 6 months of regular unprotected sex. So for those of us who are planning to marry a bit later in life, due to our career options or other preferences in life, it's a good idea to see a doctor earlier than 1 year, not one complete year. Okay, so the next slide. Infertility, as we know in OB/GYN practice, is very, very common. I see at least 6 or 7 patients every day in a combined OB/GYN clinic for infertility. And in my infertility clinic on a daily basis, I would see about 20 couples to 30 couples. So it's more common than we think. 1 in 8 couple all over America is infertile. And basically what we need to do is we need to determine, is it a female factor infertility? Is it a male factor infertility? Or is it a combined factor infertility? So let's take fertility by numbers. So 3 in 1 women may have irregular cycles and make conception more difficult. In women, the fertility decreases or declines with age. It would be in the primes of the age between 20 and 24, the fertility would be about 86 to 90%, and it declines as our biological clock ticks and comes down to about 36% by the age of 40, by the time we hit our 40th birthday. And there onwards, there's a rapid decline. As we all know, that there is fertility help available in terms of IVF, in terms of ICSI. IVF is in vitro fertilization. ICSI is intracytoplasmic sperm injection. These are all IVF treatments that are available for the infertile couple. For anything that causes infertility, the treatment is available. Now, the main causes of infertility, if we divide them into female and male causes, in the female, irregular periods and anovulatory cycles or polycystic ovarian syndrome is the commonest reason for infertility. And there are other reasons which could be divided into ovarian reasons, tubal reasons, uterine reasons, as well as vaginal or cervical reasons. In the male, low sperm count or poor morphology of the sperms, something which is called asthenoteratozoospermia or poor swimmers. So these are the main causes of infertility. So 30% are multiple factors, which would be a combined factor of female, like female may have a polycystic ovary and the male may have a small problem with the sperm or a major problem with the sperm. 18% is problem with the fallopian tubes. The fallopian tubes can be diseased. There could be PID, pelvic inflammatory disease. There could be TB of the pelvis causing the pelvic inflammatory disease. There could be hydrosalpinx or pyosalpinx, which is like disease of the tube itself, where the tubes are swollen because of chronic infections. Or there could be a previous ectopic pregnancy that a tube is missing, a tube or two are missing. So that is something that causes a tubal factor infertility, and treatment of that is directly IVF, in vitro fertilization. 14% are the problems with ovulation. And then the problems with ovulation are the polycystic ovarian syndrome, as I said. In the Asian population, polycystic syndrome is the topmost endocrine problem for infertility. 18% are male factors. Male factor infertility all over the world is on the rise. And the reason is environmental factors plus family history. And 19% is other unexplained causes. So a lot of couples come to me and they may have already had investigations for infertility, both for the male and female, but the reasons are unknown. Their hormone profiles are normal, the semen analyses are normal, they have tested their tubes and they are patent, they have checked their uterus from inside and there is no polyp or uterine fibroids or anything causing infertility. So then what we say is unexplained infertility. Okay, so what is unexplained infertility? I would say it's a misdiagnosis. Up to now, whatever tests we have available in the laboratory, whatever test we have available in terms of screening, scanning, we might not be able to pick the reason at a microscopic level, and hence we just put it all under the umbrella of unexplained infertility. It is the most frequently occurring diagnosis in infertility. The overwhelming majority of these cases, actually 90% of them, are actually three major conditions. The first could be premature ovarian aging, as we were talking about the biological clock that is ticking. So the ovaries age a little bit more earlier. Or it could be tubal disease or endometriosis. Endometriosis is the disease of the pelvis which causes adhesions between the tubes, between the adnexa, between the pelvic organs, and hence makes it difficult to conceive. The endometriosis containing cysts themselves secrete an instrument which is toxic to the fetus. We call it, it's embryotoxic. So it hampers the quality of egg also. And it could be immunological infertility. And that's the most difficult one to diagnose, basically, because anything on an immunological level is difficult to test. So just winding up the causes of infertility, we have ovulation problems, which could be a hormonal imbalance, which could be polycystic ovaries, which could be obesity, which could be low ovarian reserve. Now, obesity and polycystic ovaries, they go hand in hand with each other. So if somebody has put on weight and trying to conceive, then you give them an advice of trying to have a healthy lifestyle and try to cut down on calories and also to exercise. The most important thing in our society is the lack of exercise, the sedentary lifestyle, and most of our socializing includes eating out. So that information needs to go, that drinking a lot of fizzy drinks, eating a lot of carbs, rice, etc., that gives rise to obesity, which gives rise to PCOS. It's like a vicious cycle. Tubal blockage, as we talked, could be sexually transmissible diseases, or could be endometriosis. There could be uterine problems. Uterine problems could be that the inner lining of the womb or inner lining of the uterine cavity can be impeded by presence of any polyps, presence of any fibroids, or the lining of the womb itself may be irregular or abnormal, causing these problems. What about the causes of male infertility? There could be sperm problem. The most commonest one is a varicocele. Varicoceles are bunches of varicose veins in the scrotal area, which increases the temperature of the scrotum and hence increases the chances of having male infertility due to poor sperm production due to increased temperature. And it's very easily diagnosed with a simple scrotal ultrasound, non-invasive ultrasound. There could be a history of trauma in childhood. There could be diabetes. There could be sexually transmissible diseases, or there could be obesity. Also, males can have hormonal disorders. Male can also have genetic disorders. So again, a full, complete history is also very important. So our next few slides will talk about how to take a history for a female and a male in terms of infertility. Okay, so let's talk about that. The first and the most important thing is that mostly the wives come to you with a female relative and they say that we are trying to conceive. So I would always encourage them to come with their partner with whom they're trying to conceive. So see the couple together, and this is going to be a long appointment. It cannot be handled in a regular busy OPD with a lot of shouts and with a lot of voices in the background. So you need to have a good 30 minutes with the couple in the first appointment. So in terms of female, check her age, check her weight, and ideally the basic body mass index, BMI. Check her parity. Has she had any previous miscarriages? Has she had any previous babies from any previous relationships? Or this is her first time that she's trying to conceive? Check about duration of infertility. It is very important. Sometimes the couples are very anxious. There are social pressures from back home, and they say that we are married for 3 months and we are very anxious. So you would reassure them, give them preconceptual folates, and send them back home. But if they are too adamant, you can test them. But by and large, if you remember the definition of infertility, it is above 35 years of age female. Test them after 6 months of actively trying, or a couple below 35 years of age female, test them after 1 year of actively trying. So determine if it is a primary infertility, that she has never been pregnant, or secondary infertility, that she has been pregnant before, it was a successful pregnancy, or it ended up into a miscarriage or an ectopic pregnancy. So there will be a lot of clues in the previous history as well. Any previous fertility treatment and outcome. So if they tell me, so the first thing you ask them is this the first time you're seeing a doctor for this, or have you seen a doctor before? Can I see your previous reports? Have you taken any medications before for fertility treatment? Any ovulation induction medications or any treatment like that? The second thing is any previous medical scan reports or hormone profile reports. So any previous scan reports or hormone profile reports would be beneficial, so that you will understand if there was any thyroid disorder, if there was any polycystic ovaries, if there was any prolactin disorder, etc. We'll talk about the test in the next slide, what test we need to do. Another very important thing in our part of the world is marriage consanguinity. Marriage consanguinity means if they are married into the family, first cousins or second cousins. So basically, there are certain diseases running in the family that you would need to be aware of. Any children from previous relationship we already talked about, any periods history. Periods history is very, very important. That is her periods irregular? They coming on time. Now, always remember that ladies usually think that their periods are irregular, but they are not. So according to International Classification of Irregular Periods, please remember that as long as the periods are coming within 15 days of the previous date, they are regular. So periods history is very important. How long did the period last? How many days? Is the flow okay? Is she suffering from any symptoms like pre-period spotting or after period spotting? So it's if she says yes, or any spotting after the after having sex, after having intercourse, then it is important to check the cervix, put a speculum and check the cervix for any erosions of the cervix and do a pap smear. So that is very important. Any previous medical or surgical history is also very important, folks, because any thyroid disorder can cause infertility. Any prolactin disorder can cause infertility. Any previous surgeries, for that matter, can cause infertility. Surgeries inside the pelvis. Say, for instance, somebody has had previous 1 cesarean section or 2 cesarean section, or a history of appendectomy as a teenager, things like that, that can cause adhesions in the pelvis, can cause tubal factor or ovarian factor infertility. Ask about any painful periods. So if she's saying that, yes, my periods are very painful, to ask them if she's taking any painkillers for painful. Is it hampering her social life? Is she cutting down on her work or university, or that she has to stay at home because of pain. That could point towards endometriosis or ovarian cysts. So she needs to have a pelvic ultrasound to see that, or perhaps more gold standard, a diagnostic laparoscopy to actually directly check if she's having endometriosis. So medical surgical history is so important. I cannot emphasize more enough. Any allergies, any previous allergies, very important, again, from your exam point of view, as well as from a one-to-one patient interview point of view, because once you're going to prescribe any medication, it's important that we know if she's allergic to any components of the medications that we are giving. Family history, again, is very, very important in infertility. Ask about any history of infertility in both sides of the family for the female as well as for the male. Any history of any abnormal babies in the family, especially if it is a consanguineous marriage. And then any family history of any ovarian, uterine, cervical diseases or cancers. So that's very important. Social history, again, is important. What do you ask specifically for infertility in social history? Do you smoke? Do you drink? Do you sit socially with people who smoke on a regular basis? What is the nature of your job? Because, I mean, if it involves dealing with environmental toxins, then you need to talk about that. What is your staple diet? How much sleep you're taking, etc. How much is the stress factor when you're here for infertility? How much is the harmony between you and your partner that you're trying to conceive? So don't let the stress of infertility kick in between the relationships. That's very important. So you become their doctor as well as their counselor when you're talking in the first visit, remember? Now, in the male partner, again, the age and weight is important. Previous children from previous partners is important. Sometimes they will come to say, I have a previous relationship and my child is that much of age. So if the child is more than 1 year old, you will still need to test the male. Again, medical and surgical history is very important. Childhood mumps, very important. You ask the man if he has had any viral illnesses as a child. Ask him to ask his mommy. She would tell that yes, you had mumps or rubella or anything like that as a childhood. So mumps can cause male factor infertility. So it's very important to elicit that history. Any previous semen analysis that he may have done, ask for the report. Again, any family history and social history, especially of drinking and smoking, is very important. Smoking causes male factor infertility. Smoking in female or passive smoking in female can cause tubal factor infertility because it stunts the microcelia inside the fallopian tubes, which are meant to vibrate during the shifting of the egg from the ovary into the uterus while it is fertilizing. So if the microcelia inside the fallopian tubes are stunted, that will not happen. So that will cause a tubal factor infertility, can cause the embryo to deposit then and there in the tube, and can also cause an ectopic pregnancy. So don't take this advice for smoking cessation lightly. Please advise them against smoking, against drinking on the very first visit, both the partners. Okay. So when we are investigating, as I said, please ensure that you are seeing both the partners together, because you have to investigate both the partners together as well. So there will be lab test, blood tests, there will be pelvic ultrasound, there will be a pap smear, there will be a tubal patency check, there will be semen analysis, and there will be a scrotal scan. So what lab test do you do for the female? Think about the female genital tract. So there is ovaries, which are linked to the hypothalamic axis. So you have to test the ovarian hormones, which are FSH, or the follicle stimulating hormone, and LH, or luteinizing hormone. Also, you need to check the prolactin, because high levels of prolactin, the commonest cause of high levels of prolactin is stress. When such couples are coming to you, they are already stressed. The best time to check the prolactin levels are in the morning around 11 a.m. and tell them to de-stress themselves as much as possible. The fourth hormone to test is the thyroid, TSH. You do a full thyroid function test for them. In the pelvic scan, what you're looking for is the contour of the uterus. If there are any fibroids or any polyps in the uterus, check the ovaries for any possibility of polycystic ovaries. check the tube that there is any obvious hydrosalpinx that is imminent on the ultrasound. So a simple transvaginal pelvic ultrasound gives you a lot of information. If it is normal again, then you can reassure that your uterus was normal, the adnexes are normal, the tubes are normal, etc. Pap smear. Pap smear is a good opportunity for you to do a pap smear, which is a routine screening for cervical cancer for all women of reproductive age who are sexually active. So do a pap smear, and especially do a pap smear if they are complaining of any pre-period, post-period, or post-sex spotting. Tubal patency check is also important. It is done either through the vagina, putting in a dye, or more gold standard through a laparoscopy, where you can see and visualize the tubes directly through your eyes while somebody is pushing the dye from down below through the vagina. It's seen as blue dye coming out inside the pelvis. Semen analysis has got 7 or 8 different parameters. It checks the count, which is important. It checks the morphology. It checks the motility. It checks if there is any infection in the semen. So it gives you a lot of information instantly. It has to be done with an abstinence of at least a minimum of 3 and a maximum of 5 days. So you inform them that they have to go to the semen laboratory and they should produce a sample, which is after masturbation, 3 days after masturbation, or minimum 3 days and maximum 5 days after masturbation, or having sex. Then if they are giving history of, because when you examine them, they may show varicocele, or they may give you any history of a low libido or poor performance or poor erection. So you need to do a scrotal scan for them and take a detailed history of male factor infertility then. There are specialized doctors called andrologists who you can refer to if you are not yourself comfortable in doing scrotal scans or checking for male factor infertility. But by and large, please check, examine, and investigate both the couples together, because examining one is not enough. In our community, in our society, it's very common that the woman would come first and say, check me first, and then if everything is okay, then he will come. So you have to sit with them on a couple of occasions before you can be in the comfort zone with the couple to make sure that both of them are tested together. Okay. So female in blood works, these are the female blood works: follicle stimulating hormone, luteinizing hormone. These are both the ovarian hormones. Now, always remember that the best time to do the follicle stimulating hormone and LH hormone are during the periods. It would be tested on the 2nd or the 3rd day of the period. The rationale behind that is that on the 2nd or the 3rd day of the period, the follicle stimulating hormone is higher than the luteinizing hormone. In the later stages of the cycle, where the ovulation surge has taken place, which is usually between day 12 to day 14, the LH hormone will peak up, will rise up. So if the LH hormone is higher than the FSH hormone in the periods days, 2nd day of the period, 3rd day of the period, or the 4th day of the period, that is not normal. That points towards luteinizing hormone insufficiency, that points towards early luteinizing hormone surge. This is something that is characteristic of polycystic ovarian syndrome. So again, I will repeat it, that doing and testing the FSH and the LHs on the 2nd or the 3rd day of the periods, during the periods, if you find that the LH is higher than the FSH, that points towards hormonal imbalance, because during the period, the FSH should be slightly higher than the LH. You test the prolactin comes high, then you test for further causes for raised prolactin. The first one of them is stress. So you emphasize on de-stressing with yoga, with exercise, with going to a spa, with having harmony between the couple, etc. And then also implore into other causes of raised prolactin, which could be pituitary microadenoma or macroadenoma. Now remember, the level of prolactin have to be 1,000 and above to offer a pituitary MRI. If it is between 500 or 600, you explore for other causes as well. There are at least 100 different medications which can increase the prolactin level. The most common of them is the painkillers. If somebody is taking a lot of paracetamol and a lot of over-the-counter vitamins, etc., their prolactin will be high. So you need to ask them in their medical history if they are taking any medications. That is very important. And then when you are checking the prolactin, it comes high, that will give you a clue. And then prolactin is simply treated with giving some cabergoline medication for a month or two. Okay, and then the thyroid hormone, TSH, thyroid stimulating hormone. Thyroid disease and polycystic ovarian syndrome sometimes run hand in hand, raised prolactin included. So you have to test the thyroid hormones and starting them on a simple 25 to 50 microgram of thyroxine if the TSH is high is very beneficial for treating the infertility. Rubella IgG, rubella screening or the German measles screening is very important. Why? Because if rubella is being caught in the first trimester of pregnancy, it can damage the fetus. So hence, if somebody is found to be rubella non-immune, IgG negative that is, then offer them a vaccination for rubella before you start the fertility treatment. They are advised not to get pregnant for 1 month after having rubella vaccine. So it's very easy screening, simple blood test, gives you protection against rubella infection in early pregnancy. The last one to test is anti-Mullerian hormone. Anti-Mullerian hormone is a direct relation to the fertility aging, the ovulatory aging. So always remember that in the female, the egg count is determined on the day she was born. So the eggs on an ovary are like clusters of grape. Each month she ovulates and one grape is gone. It does not come back. In the males, however, the semen, they replicate, they are formed, new semen are formed every 3 months. But in female, that is not the case. So once all those bunch of grapes are slowly gone, she is low on ovarian reserve. And if she's trying to conceive and she's low on ovarian reserve, the AMH, the anti-Mullerian hormone, will be low. So that gives you a direct idea. Like, it is very important in modern day fertility clinic to do an AMH testing. Now, I have put down these basic female fertility lab works because there are a lot of other tests that sometimes are needed, but I'm not going into the details. Like, say, for instance, if somebody is testing positive for polycystic ovarian syndrome, like on an ultrasound, there are polycystic ovaries and their FSH, LH are, the ratio is reversed in the first testing. That is, the FSH is low and LH is high during the periods. So that is polycystic ovaries. Then you can individualize your treatment and do further lab work for the polycystic ovaries. You can do fasting insulin test, you can do testosterone test, you can do dihydroepiandrosterone or DHEA testing. So all those testings are specific for if something is found. When you're doing a TSH, if the TSH is high, then obviously you will do the full thyroid function test. You'll do the free T4, free T3, thyroid autoantibodies, and you will also do a thyroid ultrasound. So everything has its repercussion. Anything that comes positive then has to be tested in detail and depth. So what are you going to do for counseling now that you have done the tests? You have sent the test and you are finishing your first consultation. So you advise preconceptual folic acid 1 milligram to the female. If her age is above 35, then you advise her 5 milligram folic acid. Folic acid has to be given at least 3 months preconceptually and during the first 3 months of pregnancy to avoid neural tube defects. That's the rationale behind starting preconceptual folates for the female. Now, and the most important advice that you will give to the couple is harmony between the two, regular unprotected intercourse 2 to 3 times a week while they are being tested also. And also to make sure that they improvise their unhealthy lifestyle. So a bit of exercise, tell them there's no need to join an expensive gym or anything. Everything is available on YouTube these days. So most important thing is just do some regular exercise once or twice a week, as well as eat healthy. Always tell them that the solution of infertility is at least 30 to 40% in their kitchen, what they eat. We are what we eat, and infertility is no different. So most importantly, that's what we need to do, is to tell them to cut down on smoking, to tell them to cut down on drinking, to tell them to cut down. Now, some people think shisha is not, or hubble bubble, or the hookah is not uh, considered under smoking. So when you're asking about the history of smoking, please be very specific. Ask them about cigarettes, ask them about hash, ask them about shisha, and also about their lifestyle. Again, in terms of male, you ask them in particular what type of job is it, because most of the couples these days are leading a sedentary lifestyle. So if their job involves sitting for too long, you tell them to take frequent, small walks in and around the office. Tell them to take daily showers. Tell them to avoid tight fitting underpants and underwears. These are all important for the proper scrotal temperature, for a proper sperm production. So everything has a rationale behind them. And again, if the female has used too much contraception in the past, then again, that could be one of the reasons. But it's easily solvable by improvising the lifestyle as well, that all the hormones will eventually come back to normal. Obesity is an epidemic all over the world. None of the countries are different. And people think that, gaining a bit of weight after wedding, after marriage is okay. But like, especially when the couple is trying to conceive and not being able to conceive, then an advice about calorie intake, advice about exercise would be a good idea. Okay, so I'll talk in detail about ovulatory infertility because there are about 40% of female infertility cases concerned with the development or release of eggs from the ovaries. So either we have irregular ovulation or we have no ovulation at all. And common causes of them are polycystic ovarian syndrome, hypothalamic dysfunction, endocrine disorders, abnormal BMI, raised BMI or very low BMI, high stress levels. And again, elicit the history of irregular period. How irregular are them? If they are within 15 days of the previous period, they are not irregular. And sometimes it is okay if somebody is diagnosed with polycystic ovarian syndrome, they will not have 12 periods in a year. They will not have a monthly period. So for PCOS, it is okay to have 5 to 6 periods in a year, and that is still acceptable. Now, when you're treating their infertility, these are the patients who will need the ovulatory medications to induce ovulation, and we'll talk about them in the next few slides. Also, the treatment, again, for ovulatory infertility is, I tell the patients with PCOS that 70% of their treatment lies in their hand, in their kitchen, and in their lifestyle, and 30% will be the medications that we will prescribe them. So it is very important that they have lifestyle changes. Uterine infertility. Uterine infertility can be an anomalous uterus, which is an absent uterus. You can't do anything about that. Offer them surrogacy. Offer them, in developed countries now, the uterine transplant is coming up for such patients, so, which is a very promising new development. And there are successful pregnancies after uterine implant. Uterine anomalies, these are Mullerian duct anomalies. They can be complete uterine anomaly, which divides the uterus into two uteri, small uteri, and hence it is difficult to conceive. Or there could be abnormal growth inside the uterus. So the uterine anomalies can be that the uterus is unicornuate, that there's only one uterus. I did a hysteroscopy patient yesterday. She came at 18 weeks. She did manage to conceive, but had a heavy bleeding and had a miscarriage. And when we scanned her, her uterus was unicornuate, something which is shown in the diagram on your lower left. And there could be bicornuate uterus. This is the most commonest variety of uterine factor infertility, as well as diagnosed during a cesarean section. Bicornuate uterus, where there are two horns of uterus, pregnancies in one of the horns, placenta is in the other horn, etc. It could be a uterus diadelphys, that complete division of the Mullerian duct, and it makes two uteruses, two vaginas, two uteri. Or there could be a septum, simply a septum inside the uterus is called a septate uterus. And because there is a septum inside the uterus, it's difficult to conceive. So you do a hysteroscopy, you do a camera look inside the uterus, and then you remove the septum at the same time. So all these modalities need ultrasound, need an MRI scan with the contrast to diagnose them correctly, need a dye test, which is called a hysterosalpingogram, to dye goes inside the uterus to see the contour of the uterus. So, these are certain different tests, like a hysteroscopy is a direct look inside with a camera. A dye test is an X-ray look inside with a camera. MRI is also another gold standard to have to diagnose these Mullerian duct abnormalities. Remember, when you're suspecting a Mullerian duct abnormality, like say for instance you send it for an ultrasound, it comes back and it says a biconuvate uterus or a uniconuvate uterus. So you offer them an MRI abdomen with contrast. Why? Because Mullerian duct abnormalities can also give rise to an isolated single kidney or a double ureter, a single ureter, etc. So you have to outrule genitourinary abnormalities, congenital abnormalities in that sense. Okay, tubal factor infertility. Tubal factor infertility could be a simple salpingitis, which is infection of the tube, and it causes release of embryotoxic substances within the contour of the uterus, hampering the cilia, stunting the growth of the microcilia inside the tubes, and hence causing a tubal factor infertility. It could be endometriosis, these endometriosis spots, which are like blood spots, will bleed within themselves at every period, hence causing pain in the pelvis and hence causing sticky substances release around the adnexa, causing stickiness and gluiness, and hence causing infertility because of adhesions, as well as the toxicity of the chocolate-colored substances or spots or cysts hampers again the proper development of embryo, proper development of egg as such per se. There could be hydrosalpinx, again, previous old infection. In our part of the world, TB is very common. So again, checking the tubes is very important. The gold standard is a hysterosalpingogram or a laparoscopy or dye, or a HICOSI or a hysterosalpingo contrast sonography, which is without radiation. So these things are very important. Now, tubal patency testing, I just put in some pictures for you to have a look. On the left, the one with the X-ray, that's the hysterosalpingogram. You can see that the contour of the uterus is clearly seen from inside, and the dye is coming out from both the tubes, and it is coming out in the pelvis. So you can see the convoluted tubes and the dye spillage. The center picture is how this test is done by putting in a small catheter through the vagina and putting the dye through the vagina. Same as the rationale in a laparoscopy and dye, that somebody sits at the vaginal end and pushing the dye while the other operator is checking through the laparoscopy. The laparoscopic picture is given on the right of the screen. You can clearly see the blue dye coming out of the fallopian tubes. That's the fimbrial end of the fallopian tubes, and you can see a good spillage of the dye within the pelvic cavity. Now let's talk about the male factor infertility. No sperms, low sperm count, low sperm motility, pus and semen, anti-sperm antibody, less semen formation, absence of ejaculation, dead sperm, and also erectile dysfunction. So all these are male factor infertility. So again, you will tell the couple for lifestyle modification, you will address the cause, you will address mental health, this is very important, give preconceptual folates and rubella vaccination, and refer to infertility unit. If you find any tubal factor infertility, they will benefit from having in vitro fertilization, which sort of bypasses the tubal factor. Or if there is a long-term infertility, more than 4 or 5 years, don't sit with them and giving substandard treatment. Refer them to the fertility clinic. They will again benefit from the IVF. If there is ejaculatory infertility or poor performance in terms of poor erection, then they can still benefit from any intrauterine insemination. So again, referral to an infertility clinic will be more beneficial. Before the initiation of IVF, the importance of lifestyle modification should again be stressed. Weight loss should be structured, like you just don't give an advice, refer them to a dietitian, refer them to an exercise specialist, and smoking cessation, reducing alcohol consumption again is important if you're sending them for an IVF. Okay, so managing infertility means that we need to address the cause. If it is ovulatory problem, we need to induce ovulation after improving the lifestyle and after giving advice for weight reduction and giving advice for smoking cessation and preconceptual folates. If it is a tubal blockage, send them for IVF. If it is uterine problem, do a hysteroscopy, remove the fibroid, remove the polyp, or remove the septum. If it is male factor, refer for andrology. There are ways of, even if the sperm count is 0, a testicular biopsy, they can extract sperm through a testicular biopsy and then can go for an IVF. So there are a lot of things that the infertility clinic and the andrologist can do for you to make this couple pregnant. Okay, let's talk about managing infertility for PCOS, ovulation induction. So these are the drugs used for ovulation induction: clomiphene citrate, which is the most commonest one, gonadotrophin injections, tamoxifen, aromatase inhibitors. So the most common ones that we use are metformin, which is glucophage, which is given to people with polycystic ovaries. It brings the resistance against insulin down. Metformin is standard treatment, as you know, for type 2 diabetics, but it is also given for patients of polycystic ovaries. It is not an FDA approved drug for polycystic ovaries. You have to tell the patients that. It will cause stomach upset in the initial few weeks, so the dose has to be gradually pulled up. The standard dose is 500 milligram, one in the morning, one in the evening, after breakfast, after dinner. So you have to tell the patient that they have to take a healthy breakfast, because most of us don't take breakfast because we are busy in our lifestyles. So metformin is basically given to bypass the resistance of insulin that the polycystic ovarian syndrome patients have. The second thing is Clomid or Femara. Clomid is again given to induce ovulation. It has to be given from the 2nd day of the period to the 5th day of to the 6th day of the period. Is given for 5 days, and then you do an ultrasound between the 12th and the 14th day to see if they have grown a mature ovarian follicle. You follow that, and once the lining of the uterus is appropriate, which is between 8 to 10 millimeter and above, and the size of the egg is mature enough, which is 14 millimeter and above, then you give a trigger injection and ask them to have sex on the evening of the trigger injection and the following day, and that increases their chances of conceiving. Every drug has a side effect, as I said. Glucophage can make the stomach upset, so that you tell the patients to take the glucophage once every day for the first 2 weeks. Once their bodies are used to glucophage, then increase the dose to 2. Clomid also, if given for more than 4 or 5 cycles, can dry the lining of the womb, can dry the uterine lining. So basically you might not be able to achieve the above 10 millimeter lining of the womb. So Femara has overgone that problem. So Femara is slightly superior to Clomid in that sense. Excessive use of ovulation induction drugs over a period of 2 to 3 years can cause ovarian cancer. So be very careful. You have to explain that, because Clomid in some parts of the world, including Pakistan, are available over the counter. So ask specific history when an infertile couple comes to you. Have you been taking any infertility treatment, and for how long? And you won't be surprised. The patient will tell you, oh, we have taken 8 cycles of Clomid, or we have taken 12 cycles of Clomid. So you cannot give Clomid to such couples then. You will clearly tell them that you will be at risk of ovarian cancer if we give you more. Else about that. Okay, managing tubal factor infertility. If there is adhesions, that will be imminent on the laparoscopy. You have to do a diagnostic laparoscopy. And if they are flimsy adhesions, they can be easily cleared on laparoscopy. Otherwise, send for IVF. If there is chronic salpingitis, you can see infection, cyst, or things like that. do an IVF, and before IVF, it's a good idea. I would normally clip the tube so that the toxic fluid inside the tube will not hamper the IVF treatment, because those fluids, those gooey fluids, which makes the tube swollen, that will be embryotoxic as well as and can cause failure of your IVF as well. So it is a good idea to have a conversation with the couple before going in for a laparoscopy and take a consent for a salpingectomy. You remove that disease tube altogether because you're not going to need them at all, and you can go for IVF directly. Excuse me. If somebody has had tubal ligation in the past, then it's a good idea to do an open microsurgery. But however, the expertise all over the world is sort of fading away because of the IVF, because of the IVF has been so successful that the tubal microsurgery, by putting in cannulating the tubes and restructuring the tube, has gone down. The skill has gone down. So again, if you don't have the skill, then sending for IVF is a good idea, or send to somebody who has the skills for that matter. Again, uterine factor infertility, a polyp or a myoma or a fibroid or a septum can all be easily taken care of nowadays with a minimal invasive surgery called hysteroscopy. It takes about 30 to 40 minutes to remove these kind of fibroids in a very, very modern method. It's called HystroSure, and it's like a camera, and the thickness of the camera is the size of a common ballpoint pen. It goes inside, you're looking at what you're doing, and then basically you just remove the septum, or you remove or shave off the fibroid, or shave off the polyp that is there. Give them 6 months to heal, and after 6 months they can conceive, or you can take them for IVF. Male factor infertility, again, pre-testicular, testicular, or post-testicular. They could be endocrine, so that's why hormone testing of the male is also very important. They could be genetic, congenital infections, or immunologic, or anti-spermatogenic agents. So again, their history is very important. The drug history is very important. Their lifestyle history is very important. Some people, you'll be surprised, working in leather industry, working in tanning industry, working in agricultural industry. So agricultural pesticides, leather dyes, tannins, all these are sperm toxic, and they cause male factor infertility, subhanallah. So you have to be very, very particular about the history, social history of the male, and ask all these things before you make a conclusion. Post-testicular, it could be an obstructive cause, or an epididymal hostility, or a gland infection, or again, it could be immunologic. So every problem of male factor infertility is dealable, is fixable. If the sperm count is 0, as I said, testicular biopsy is a good idea. Do a TZ, it's a trans epididymal sperm injection or extraction. And then the other things is that take a hormone profile for the male, again, FSH hormone, LH hormone, thyroid hormone, testosterone hormone, as well as prolactin hormone. So these are the hormone profile that you will do for the male. So the one extra thing is the testosterone that you will test for. And then send to the andrologist and let them see the patient. If it is a male factor infertility, it will be greatly beneficial. So these are certain infertility treatment. The first picture on the left is the intrauterine insemination, where you take the sperms through and ejaculate in a lab. You wash the sperm, you process the sperms, and then you inject it in the vagina of the female partner. When do you inject it in the vagina of the female partner? Well, you have primed the uterus, you have primed the ovaries by giving her ovulation induction medication. And on the day of ovulation, which you have confirmed with an ultrasound and confirmed with a test of LH surge, which is progesterone test, then you will bring the lady inside your office, prepare the sperms at the same time in the lab, and then inject that, and that's it. She walks out. After 2 weeks, tell them to do a pregnancy test. The success rate of IUI is about 10 to 15%. Every 10 couple who will have an IUI, out of them, one will get pregnant in the first go. So if it is and remember, if it is a tubal factor infertility, that the tubes are not working, then IUI is not a good idea. IUI is reserved for those couples where where you have tested the tubes, where you have done the test for the uterus. There are no problems inside the uterus, and the semen is also normal. There's a slight problem with the polycystic ovaries that you have treated already with glucophage, metformin, and with Clomid, and now she's ready to conceive. So you do the IUI in such cases where it is okay, acceptable, because the success rate of IUI is about 10 to 15%. So don't waste their time if they have a tubal factor infertility or a sperm factor infertility or a uterine factor infertility. It will not work and their money will go waste. The second thing is an IVF. We call it a solution to every infertility problem, but in actuality, it may not be. In IVF, what you do is that, again, you take the sperm, you wash the sperm, you prepare them. And again, you prepare the female also, you give her medication, you make more than one eggs ripen up, which is called super ovulation. And then you collect the eggs vaginally through a minor procedure in the lab when the time is right. You have to sedate the lady and you have to collect the eggs vaginally through a fine needle. And then these eggs are taken to the laboratory. They are put in a petri dish and they are sprinkled with the sperms. And within the next 2 days, the fertilization happens. And then those embryos are tested under the microscope, and the good quality embryos are being transferred inside the womb when the day is correct. Usually you will put in 1 or 2 embryos, not more, because there is a chance of multiple high order pregnancy with IVF. So that's the way the IVF is done. Any embryos which are extra, they can be frozen for later stages for the future use. But this is a very good way. The success rate of IVF is about 35% all over the world. So again, 10 couples going for IVF, 3 to 4 will conceive in the first go. Again, IVF is an expensive treatment, so you counsel the couple that they should have monetary funding for at least 2 to 3 cycles of IVF before they go for trying, because after the failure, basically the couples go into a lot of depression, a lot of money has gone into it, a lot of medication, injections are gone into it. It makes you really, really depressed even to see those couples, and you can understand the agony and the trauma for those couples if the IVF fails. So all this counseling has to be done in the IVF clinic. IVF clinic has got special counselors for these kind of pre-treatment and post-treatment counseling. Okay. So, but any of these advanced fertility treatments have got risk, ovarian hyperstimulation being the most important one. It is a medical emergency. It is a iatrogenic emergency. We have caused that, so we have to treat that. It requires high dependency care admission, etc. And then there could be multiple pregnancies. So again, high order pregnancies when you are telling the couple, look, you can end up having twins or triplets, they're smiling. They say, oh, mashallah, alhamdulillah, very well. But no, it is high risk. It is high risk for miscarriage. It is high risk for preterm birth, neonatal intensive care, transfer for the babies, and congenital anomalies in the babies if they are born too much premature, that their system is not completely developed. IVF treatment can also end up in a miscarriage, can also end up in an ectopic pregnancy. There's risk of failure and there's high cost, as we discussed earlier. So your take-home points from today's presentation would be: tell the couple to take help after 1 year. Please see the couple together. Make a history template for both the partners. Make a set investigation for both the partners. See them again for result interpretation and individualize their management plan, and refer to infertility specialized services if you think that they will need that. There is a small link to nhs.uk website for infertility. So all the information what you want to read is on that website. So you can take a picture of this slide. This brings us to the end of our topic lecture for today. I put these pictures for you. They might interest you. This is Louise Brown. Louise Brown is the world's first IVF baby. She was born on July 25th, 1978. She's in her 40s now. That's her with the professor Patrick in the bottom left picture, and she has her own son with her in this picture. It's a beautiful picture. Louise's mom had tubal factor infertility, and she was treated for that successfully, and Louise was born with a cesarean section. She's a very popular name in the world of infertility. She attends a lot of international conferences and gives her opinion about IVF as well. The point of showing you this picture is that there is hope in the world for all the infertile couples, and IVF has come a long way from going just from IVF to ICSI, which is the intracytoplasmic sperm injection, to blastocyst culturing, to genetic testings of the embryo to ensure that it is not a diseased embryo, etc. So there has been so much evolution in the world of infertility that it is phenomenal. There are newer researches, newer methods coming every day. So you can find Louise Brown on Twitter. She's very active on Twitter as well. And this brings us to the end of our lecture today. Thank you very much for listening. And if you have any questions, you can email me on shaziatarik9@yahoo.co.uk. Thank you, everybody. And this educational activity was supported by JSMU.